Hi, I'm Dave Hashi. I'm a professor and a pharmacist at Idaho State University with the Department of Family Medicine. And in this unit, we're going to be talking about HIV. I have no financial disclosures, but I have participated in the HIV National Curriculum. And the objectives in this unit are a little bit larger. We're going to be talking about some of the epidemiology of HIV, the regional and national. You should be familiar with some of the screening tests for HIV and how those screening tests may be confirmed. We will look at some public health concepts on the HIV care continuum and the care cascade. You should be able to identify resources to link patients to care should you be working with individuals living with HIV. We'll talk about strategies to retain people living with HIV, as well as recognize common medications used to treat HIV. And lastly, when we talk about disease prevention, you should be able to provide some harm reduction strategies for persons at risk for acquiring HIV. Before we dive into the epidemiology, there is one thing I want to mention. We're going to be using person-first language. And what that means is we're going to be using the person first, as opposed to the disease. We do not say anymore an HIV patient or an HIV-infected person. In that context, the disease defines the individual. However, we want to recognize the person, and therefore we say person living with HIV. And we should do that with all diseases, not just HIV. And that brings some humanity, and it brings the person out rather than putting the disease first. So starting with epidemiology, we're going to talk about prevalence. And again, what prevalence is the number of persons living with HIV, in this case, in the U.S. And you can see over the last several years, it's going up to 2019, that there's about 1.2 million persons living with HIV in the U.S. And when we look at the annual incidence, this has been slowly declining. And the U.S. does have some national HIV and AIDS strategies goals at eliminating HIV by 2030. That is what we refer to as EHE, or ending the HIV epidemic. And there are different national strategies, state strategies to eliminate this. And you can see we're not getting there yet, but other tools such as better screening, better treatment, as well as HIV prevention strategies are slowly reducing this, but we need to get better. How is HIV transmitted? HIV is primarily transmitted either through unprotected sexual intercourse or through injection drug use. And that's in the United States. Globally, it is still transmitted in parts of the world from mother to child transmission, either during pregnancy, at birth, or through breastfeeding. But in the U.S., primarily it is male-to-male sexual contact through insertive or receptive anal intercourse. You can see other small areas of transmission, less common than male-to-male sexual contact, whether it's heterosexual, injection drug use, or some combination thereof. When we look at the different racial disparities, the words that come to mind are health inequities or health disparities. And when we look at Black African Americans, they have the highest rates of HIV acquisition in the U.S. And one statistic that really stands out is if you are a young, gay, Black man, your risk of contracting HIV in the U.S. is about 50%. And with our progressed national health system and our medications, that in today's age is unacceptable. So this slide really highlights some of the racial disparities and how programs need to exist to support and target and create some interventions in these communities where there is social inequities. And when we look at this map, and this map is from AIDSview, a online website that that was introduced in Unit 1, what this emphasizes is the darker the colors, the more highly concentrated the cases of HIV in the U.S. So what you should be able to identify from this slide is that the rates of HIV in the U.S. are most prevalent in the Southeast and the East. And when we look at this, this is also where there are heavy populations of African Americans, rural, poor access to health care. So there are lots of influences that, that create some of these inequities. Also, when we look at Idaho, you can see Idaho is one of the states with very low HIV prevalence. And because of that, Idaho has fewer resources for people living with HIV. Moving now to screening. This can be a very complex process to understand. So these are some general principles in understanding screening. All persons between the ages of 15 to 65 should have at least one HIV test in their lifetime, regardless of risk factor. And the way that HIV is screened for is usually with a rapid HIV test. And from this website, you can see that days following HIV acquisition, there are different tests that can identify different aspects of the disease. Usually within 10 days, the amount of virus is detectable in the body, but that is not a screening or diagnostic test. Usually the fourth generation antibody antigen test, looking for either parts of the virus or the body's immune response, is acceptable at screening for HIV. It will identify HIV usually within a few weeks of exposure to the virus. The older tests, either the third generation and a test we don't use anymore, the Western blot, take a lot longer. So somebody who has an exposure to HIV should understand that it takes several weeks before their body creates markers that can be picked up on a screening test or a blood test. If a screening test comes back positive, then that test needs to be confirmed. And usually this test is sent out to a lab, and the first test that is done is the antibody antigen immunoassay. If that comes back positive or reactive, then the lab will do a further differentiation assay to determine if this is HIV-1, HIV-2. Sometimes it will come back as indeterminate, and if that's the case, that's when checking for the viral load or HIV RNA would be indicated to see if this might be an acute infection. Again, this is a fairly complex process, and if you are looking for support, calling your local health department or HIV clinic to help you navigate some of these resources. When we look at these screening tests, we need to talk about the test sensitivity and specificity. And when we look at this slide, what we're talking about is if we took 50 persons infected with HIV that were known to be living with HIV, and we screened all of them, one person would have a false negative. So the sensitivity rate is about 98%. Specificity, on the other hand, is taking patients without a disease and appropriately screening them as negative. So if we had 50 patients who are known to be negative, there may be 2 individuals that have a positive or a false positive test. So the specificity in this case is about 96%. There are lots of reasons why individuals may have a false positive. Some vaccines may cross-react. A lot of times in pregnancy, individuals may have a false positive. And in this case, it's important to reassure the patient that their are small rates of false positives, but understanding that the patient may need to undergo further testing. Two concepts to introduce in this unit are the HIV care continuum and the HIV care cascade. These are really solid public health concepts to help navigate where a patient is in care and how to drive them to be fully engaged in care. So on the left-hand side of this, we have patients not engaged in care, unaware of their infection. And as patients become more aware of their disease, how do we use resources and tools to help get them fully engaged in care so that they know their disease status, they're on medications, and they can get fully suppressed? That is really a complex system-based problem of making sure patients have access to good providers, medical case management, medications, social services to really support them to drive them down that pathway. And we can look at this in another way. In the HIV care cascade was introduced probably about 15 years ago, and other disease states have modeled off of this to be able to identify where in the disease course or in this cascade of treatment people are falling out of care, so that either public health resources, healthcare systems can improve to ensure that patients reach positive health outcomes. The first step is identifying persons living with HIV. And what we can see is that only about 85% of patients living with HIV have been diagnosed. So how do we capture that 15% of individuals who may be unaware of their positive status? Whether it's engaging public health officials in broader testing, engaging patients in educational campaigns, educating providers to be more adept at screening, lots of approaches. But then we can see patients falling off on engaging in care, being linked to care, and being retained in care. Again, almost half of patients may fall out of this. And with this, there's lots of reasons this happens, whether it's having no HIV care provider in your region. Patients may not have transportation. Patients may have substance use problems or mental health disease, preventing them from really engaging in care. Stigma with HIV, trauma, still lots of reasons. But we know once patients engage in care and start treatment, their likelihood of having a successful outcome of suppressing that virus is extremely strong. And the follow-up to that is when a patient is treated and their virus is undetectable, they do not transmit the virus. So the next step in all of this is helping patients identify a provider. And here in Idaho, the Department of Health and Welfare has a website that has a lot of the providers that care for persons living with HIV listed. There are also testing and treatment locators that you can access or provide to patients that will identify where an HIV provider is, and a lot of times if there are other clinical resources such as medical case management, pharmacy services, or other services. Now, I've mentioned the word retention, and what retention is when a patient with HIV is engaged in care, how likely is it for them to stay in care? And there are a lot of factors that you should be able to identify with lower retention rates. First of all is the place of residence. Patients who are in rural environments may have transportation issues. There may be geographic issues as well as lack of a provider. So place of residence, rural versus urban, has a lot of influence. Individuals who are younger have a harder time of staying engaged in HIV care. Data suggests that individuals who are Black or non-white, Hispanic, Asians, and Pacific Islanders have lower rates of retention compared to white individuals. Those with uncontrolled mental illness such as anxiety, depression, PTSD, trauma, all have lower rates, and controlling and treating those conditions will help keep people engaged in HIV care. Stigma, fear, active substance use, and those who are or underinsured also have lower rates of being retained in HIV care and risk of falling out of care. And this is one example of an approach to engaging different resources and tools to support retention and care. And this one highlights the importance of medical case management, patient navigation, personal contact, the public health department, providers. And so with this, it is a multi-pronged approach with a strong safety net for the patient. Next, we're going to shift gears and talk a little bit about the treatment of HIV and how HIV replicates and transmits can be a fairly complex process. For the intent of these modules, we're just going to have a very high-level view of this. As already described, HIV enters the body usually through sexual exposure or through injection drug use, most common rates of transmission here in the U.S. And once that virus is transmitted either sexually or via injection drug use, the virus can infect what's called a CD4 cell. The CD4 cell maintains the immune communication within the body, and when those cells are destroyed by HIV, then the body's immune system can begin to deteriorate over time. But the virus needs a couple different tools to be able to replicate. And the two major tools that are going to be drug targets are what's called reverse transcription and integration. But the virus can also, and also needs to repackage itself to be able to transmit to other cells and infect other cells. So when we look at this, HIV, again, is a very small virus that is encapsulated into lots of proteins. And this protein will interact with this CD4 cell, also known as a T helper lymphocyte. And when it binds to the CD4 cell, this is a potential spot for a drug mechanism, not one that is used commonly. However, after the viral components are introduced into the CD4 cell, it undergoes what's called reverse transcription. And there are drugs that can inhibit the virus's ability to do this. However, just using one or even two drugs at this site is not enough to shut down the viral replication completely. We need an additional agent. And one of the most common drugs to do this are called integrase inhibitors that work at this stage of viral replication called integration. The next step is viral repackaging and assembly as the virus goes out and then is able to infect other CD4 cells. So the bottom line from this slide is to really understand that we use drugs from different actions to inhibit viral replication. So what does this look like from a patient's perspective? There are really four, at this point, recommended initial regimens for most patients living with HIV. So most patients can get by with one of these drug combinations, and these drug combinations are recommended by the Department of Health and Human Services as first line. And without getting too complicated into the drug names, the drugs that are drug names that are listed in red are the integrase inhibitors, so either dolutegravir or bictegravir. And then the other combined medications from the nucleoside reverse transcriptase inhibitor class, abacavir, lamivudine, tenofovir, emtricitabine. So using that as a combination, either in a single tablet regimen, such as identified in the first, second, and third combination, or using two separate drugs identified in the third combination. And I used this comment earlier, undetectable equals untransmittable. What we know from very well controlled studies is that patients who take their antiretrovirals and their virus is suppressed or undetectable, which is the goal of therapy, do not transmit HIV sexually. And that's a really important public health concept, as we can use the treatment of HIV as prevention. And therefore, patients can, whether safely have unprotected sex without risk of transmitting the virus. When we talk about reproductive health, individuals can safely have unprotected sex to be able to try to conceive children. And patients can rest assured that they're not at risk of transmitting the virus. And for a lot of patients that suffer from trauma, anxiety, that do not want others going through what they've gone through living with HIV, it can be a very powerful tool and language. And then the last concept we're going to introduce is disease prevention and transmission prevention. And as I already highlighted, undetectable equals untransmittable. That's one public health concept. Also, risk reduction counseling. There can be ways to reduce transmission, such as condoms, abstinence, the use of HIV prevention drugs, and we'll get into that in the next couple slides. But what's also important is disclosure. Persons living with HIV, at least in Idaho, are required to disclose their status prior to engaging in sexual activity with others. And it may also help open up conversations of ways to understand sexual dynamics of risk reduction. And so in your states, there may be other disclosure laws, but in Idaho, it's important for patients to understand that there are still HIV criminalization laws, at least at this point in time, that patients may be accused or charged with. Condom use, regular, consistent, appropriate condom use has been shown to reduce HIV transmission. And then for individuals who inject drugs, there are syringe services to utilize clean needles, clean equipment when injecting is also important, and regular testing for those at risk. In today's age, one of the most common ways to reduce HIV transmission, one of the best ways, is PrEP. And PrEP stands for pre-exposure prophylaxis. And this is a concept by which taking a medication every day that we generally use to treat HIV has been shown to reduce the likelihood of contracting HIV. When taken consistently and regularly, this approach to preventing HIV is nearly 100% effective. And again, there are different approaches by taking the medication every day. There is also something called on-demand PrEP or 211, depending on the resources that you look at. But if somebody knows that they're going to have an HIV exposure, they can take 2 tablets 2 to 24 hours prior to sexual activity or sexual intercourse, and then 124 hours later, and then 124 hours after that. And this has been shown to be just as effective as taking it every day. And this may be an option for patients that have lower frequency of unprotected sex or risk of HIV exposure. The other nice thing is there is also a long-acting injectable that individuals can use to prevent transmission. This has been shown to be as effective, if not more effective, than taking medications every day, and patients can get injections on a regular basis to help reduce that likelihood of transmission. So bringing this all back home, hopefully at this point through this unit, you should be able to describe some of the epidemiology of HIV, understand some of the screening and confirmatory testing that's associated with HIV, understand those public health concepts of the care continuum and care cascade, be able to support patient linkage to care, help those in care stay in care, and understand some of those basic treatment and prevention concepts. Thank you.